Hello everyone, this is Dr. Suraj and today we'll be talking about amyloidosis. Amyloidosis is deposition of the amyloid in various organs and tissues. Now what is this amyloid? Amyloids are misfolded proteins basically, and they are hyaline in nature. That means they are pink substances and they are getting accumulated or deposited extracellularly. So these misfolded proteins, when elevated or combined with other proteins that are structurally mutant, they will be deposited extracellularly, and this extracellular deposition can lead to amyloidosis and can produce various conditions. Okay, we'll see amyloidosis in many of the conditions like Prions disease, Alzheimer disease. Okay, in case of chronic renal failure, in senile condition where the cardiac amyloids are deposited, we'll be enlisting all kinds of amyloids that are deposited. Okay, now this amyloids, as I told you, these are pathologic, means it's misfolded, and these are extracellular and hyaline substance, means those when we stain with H and E is giving rise to pink in color, and that is what is pink substance. So whenever we are talking about deposition of amyloid, please remember this is around 95% of amyloid which is actually combined with a specific P protein for a particular disease. Okay, which is getting deposited with specific P protein in a particular disease, like supposing in case of medullary thyroid carcinoma, as I know it is arising from the parafollicular, it is arising from the parafollicular C cells. Okay, and these parafollicular C cells are gonna produce, it's going to produce calcitonin, and when this calcitonin is mutant, this amyloid protein is going to bind with this calcitonin and produce a cal, that is very important, that is going to produce a cal, and that is the amyloid in case of medullary thyroid carcinoma. So you see the HP slide of a medullary thyroid carcinoma. This is, I told you in my the thyroid malignancy surgery and pathology video in TFS series. You just can refer to that. So there I told you and showed you that the slide of MTC, medullary thyroid carcinoma, you can identify that with the presence of this amyloid. Okay, this is the only thyroid carcinoma where it is associated with amyloidosis. So in your clinical pathologic question, if you see amyloid is mentioned and it is belonging to any kind of thyroid malignancies, then think of medullary thyroid carcinoma. There I told you this thing, this calcitonin is produced from parafollicular C cells. That's why it can be used as tumor marker for medullary thyroid carcinoma. Okay, all this pentagastrin assay, all this thing I told you there. Okay, next coming to the Prions disease. In Prions disease, guys, remember it is the amyloid which is combined with the PR. So this is what is known as APR. This is the amyloid protein. In case of type 2 diabetes, you have to remember that it is amyloid islet associated pancreatic polypeptide, AIAPP. Okay, this is what is getting deposited in the islets of Langerhans cells in the pancreas. In case of Alzheimer's, it is A beta. In case of Alzheimer's, it is A beta. Please remember, it is not A beta 2 microglobulin, it is A beta only, and that is the Alzheimer associated amyloid protein. Okay, this all are actually examples of localized amyloidosis. These all are examples of localized amyloidosis. Let us talk about the primary and secondary amyloidosis. What is this primary amyloidosis? Primary amyloidosis are, these are the most common type of amyloidosis, and here basically what happens, the amyloid protein is combined with the light chain. Okay, so that is what is happening. See here, if I have to explain you, so normally what is happening, from the bone marrow the B cells getting matured and forming the plasma cell, and these plasma cells are the one which is going to produce the antibodies. The antibody is composed of light chain and heavy chain. What happens, this misfolded many a time what happens, the misfolded light chains are produced, and these misfolded light chains will be aggregating with each other, and they will produce the AL type of amyloid. Understanding? Like in case of supposing liver is producing the thyroid transthyretin protein, okay, and that transthyretin protein is normally in tetramer form, but when their dissociated monomers are there, and this misfolded dissociated monomers will aggregate, and that will form amyloid protein, that is ATTR. That is very important. Okay, if it is misfolded ATTR, please remember this is going to, this is seen in case of familial amyloidotic polyneuropathy. This ATTR is seen in familial amyloidotic polyneuropathy. It's a familial condition. Okay, so ultimately this abnormal AL or say ATTR, these are the abnormal amyloid protein. Now these abnormal proteins can get deposited in many areas like heart, like any joints, tendons, in median nerve, can lead to carpal tunnel syndrome. Here in case of heart, the ATTR is getting deposited, that is cardiac amyloid, but here the transthyretin is normal variant, not the mutant variant like familial amyloidotic polyneuropathy, and lead to restrictive cardiomyopathy, heart failure, and various kinds of arrhythmias here. So returning to our topic, the primary amyloidosis, most common type, and here AL type is seen, means excessive light chains are there, and these light chains are accumulated and forming the amyloid protein, forming this abnormal protein that is getting deposited. So that can be seen in multiple myeloma, even the B cell neoplasms are the conditions. Okay. Next, coming to the secondary amyloidosis. In secondary amyloidosis, please remember it is the variety AA. Basically, secondary amyloidosis are seen in the background of chronic inflammation or chronic neoplasm. So once you have these conditions, there will be the chronic inflammation or chronic neoplasm in the background. There will be increased interleukin 1 and interleukin 6, and that in turn will increase the level of SAA, that is very important, serum amyloid associated protein from the liver, and this is going to increase your AA. So in in secondary amyloidosis, in chronic infections like TB, bronchiectasis, sarcoidosis, in case of rheumatoid arthritis or IBD, that is inflammatory bowel diseases, or these conditions are there, even in Hodgkin's lymphoma, okay, renal cell carcinoma, all the chronic malignancies are there. Here you will find a variety of amyloidosis. So please remember, they will ask you this question: what is the most common cause of death? Okay, the most common cause of death. The most common cause of death in primary amyloidosis is cardiac failure. The most common cause of death in secondary amyloidosis is renal failure. Okay, returning to our topic is this. Coming to chronic renal failure. See, chronic renal failure, or if the patient is on hemodialysis, okay, in that case, please remember it is A beta 2 microglobulin. It's not A beta. A beta is in Alzheimer's, A beta 2, because this beta 2 microglobulin, it cannot be filtered out of the dialysis membrane, so it will get accumulated and can lead to amyloidosis. So in case of chronic renal failure also. Okay, now coming to the senile one. The senile means in aged person, that is the aging is normal phenomena. Okay, what we see is cardiac amyloidosis also. In case of cardiac amyloidosis, okay, what is happening? The deposition is ATTR. Now here I want to mention one thing. This transthyretin, this is normal here. It is not the mutant variety. Okay, as I told you, that is amyloid with the mutant protein that is specific to specific diseases. Okay, like here the calcitonin is mutant, here the prion ka peer protein is abnormal. Okay, so these are there, but here in senile condition it is normal, because remember the aging is normal. Okay, and in aged and cardiac patient this is the normal transthyretin getting deposited. But in case of familial amyloidotic polyneuropathy, as I told you, here also you see ATTR, but here this transthyretin is mutant variety. It is mutant variety. Okay. Familial Mediterranean fever, here you will see A variety of amyloid. Also, sometime the specific one can be given like A pyrene. Okay, now these are the various kinds of amyloids that are getting deposited in specific diseases. Please do remember, these are the primary, secondary, and the chronic renal failure, hemodialysis, and these are your generalized amyloidosis. These are your generalized amyloidosis, and these are your familial amyloidosis. These are your familial amyloidosis, familial Mediterranean fever, and familial amyloidotic polyneuropathy. Now you have to diagnose this condition. So you take the biopsy. Now, if it is a localized condition, take the biopsy from that lesion. But if it is a generalized condition, then the best source of the biopsy specimen is abdominal pad of fat. Abdominal pad of fat is the best source. So you take the aspirate from the abdominal pad of fat. Okay, if not, then you can go for rectal biopsy from the rectal mucosa, but it is very much painful. So if there is macroglossitis, you can also take the biopsy from tongue. Once you have taken the biopsy, then you have to stain it. Now, the stain that we routinely use is HNE, but on HNE, as I told you, it's a high lineage material, so you'll give pink in color. But pink on HNE can be due to a sclerosis, can be due to fibrin deposition. So to specify whether it's a amyloid, the best stain is Congo red stain. Once I put the Congo red stain, it will give what appearance? Salmon pink appearance. Very important. Okay, so you stained it with Congo red, and you are watching it under light microscope. So it is giving rise. It will give rise to a salmon pink appearance. Please remember. But once you stain it with Congo red and looking under polarized light, you will see apple green birefringence. This apple green birefringence is due to the physical nature of the amyloid. So now once you do electron microscopy, on electron microscopy it will be non-branching fibrils of indefinite length with 7.5 to 10 nanometer diameter. And as I told you, in X-ray crystallography or infrared spectroscopy, you'll be having crossed beta pleated sheet, which is responsible for this apple green birefringence. Okay, but before I go for biopsy, I can put some stain on the gross specimen, and this is what is known as iodine, that is Lugel's iodine. Don't worry, I'll be showing each and every images. Lugel's iodine. Now once I put Lugel's iodine on the gross specimen, what will happen? See just the image. Once I put the Lugel's iodine, what will happen to the gross specimen? It will take mahogany brown color. Okay, it will take mahogany brown color. So if the amyloid is there, it will take mahogany brown color, and this is on Lugel's iodine, and this is not a histopathological stain, it is gross specimen mein we are staining. But after that, if I put sulfuric acid, on addition of sulfuric acid, it will take blue color. The specimen is stained with Lugel's iodine, and then the mahogany brown color will be seen. On further addition of H2SO4, the amyloidotic portion will take the blue color. That is what is amyloid. This is a gross specimen where you can see this dot things are amyloid depositions. Okay. On histopathology, these are extracellular pinkish deposition that you see. This is amyloid, and this is a renal biopsy, and you are seeing renal histopathology. These are the glomeruli. Okay, once you see that is a pinkish extracellular material, which is eosinophilic in nature. It can be sclerosis, fibrin deposition, or it may be a hyaline. So how to confirm whether it is amyloid or not? Then I put Congo red. Once I put Congo red stain, you will see under light microscope, this is what is salmon pink appearance. Now, if you see that under polarized microscopy, because of the cross beta pleated sheet appearance, this is what you see. Okay, this is apple green birefringence. Very clearly you can appreciate this one, and that is because of crossed beta pleated sheet appearance. Other stains are also there, like we can stain the amyloid with, so PAS stain can give rise to magenta colored appearance. Okay, also we can use thioflavin S, thioflavin T, those are immunofluorescent staining. Also we can use methyl violet or crystal violet, those are metachromatic stains we can also use for that. Many non-specific, so these are all non-specific stains. Okay, the specific ones are mentioned. Now the last condition that we are going to discuss here are the organomegaly. As I told you that amyloid getting deposited in the tissues and organs, so leading to uh, organomegaly, and that on gross appearance you can appreciate that there will be waxy appearance of the organ. Okay, that is very important, that is waxy appearance of the organ. Okay, so they will ask you what is the most common organ getting affected in amyloidosis. It is kidney, and kidney ka earliest feature is seen in mesangium. So mesangium is the earliest part of the kidney that is getting involved. Also you'll be getting then dhire dhire glomeruli and tubules will be getting involved. Next, the second most common organ that is getting involved is the heart, and it is the subendocardium of the heart that is earliest, that is getting involved in case of heart. It is the earliest part of the heart that is getting involved in amyloidosis, and that can lead to restriction in the movement, that is restricted cardiomyopathy, can lead to arrhythmias also. That is very important. And lastly, it can lead to heart failure. In case of liver, the space of DC will be involved first. Okay, in case of liver, it is the space of DC will be involved first, and this space of DC involvement can lead to cirrhosis of the liver. Okay, lastly, the spleen can get involved, and spleen may we have white pulp, we have red pulp. This white pulp are nothing but these are the follicles of the spleen, and these red pulps are basically the splenic sinuses. Okay, if the amyloid is getting deposited in these follicles, that can give rise to this kind of gross appearance of the spleen, where you can see that many whitish deposits that are simulating like sago grains. This is what is known as sago spleen. And this is sago spleen is white pulp or follicles are getting involved. If the amyloid is deposited in the red pulp or the sinuses, splenic sinuses, that can give rise to Lordaceous spleen. And here, because of the deposition of amyloid in the splenic sinuses, it is going to give rise to the geographical spleen basically. Okay, that is the large geographical map like areas in the spleen. Gross morphology, you will see that. So these are various kinds of amyloid proteins that are getting deposited in various conditions, and the pathophysiology, the investigations, the best stain, various organomegalies that are seen. So what is the most common biopsy? So a rapid fire, what is the most common biopsy site that we do? It is the abdominal fat pad, followed by rectal, followed by gingival. What is the best stain for amyloidosis? Amyloid is Congo red. What is the gross stain for amyloid? It is Lugol-Sidene, followed by H2SO4. Okay, what is the most common organ affected? It is kidney, most common. Second most common, heart. Okay, second most common, heart. What is the most common cause of death in case of primary amyloidosis? I told you, heart failure. What is the most common cause of death in secondary amyloidosis? Told you, renal failure. Okay, which part of the heart is earliest involved in amyloidosis? It is the subendocardium. Which part of the liver is getting affected earliest in amyloidosis? It is the space of DC. Okay, which cells are there in space of DC? Which cells are there in space of DC? Please comment it. Okay, next coming to which part are getting involved in spleen? It's sago-spleen and Laurasia spleen. Sago-spleen, it's the follicular white pulp getting involved, and red pulp is getting involved in Laurasia spleen. Okay, so if someone is saying that there is a diabetic patient who is on dialysis, what kind of amyloid will you see in this patient? Okay, so you will see, because the patient is on dialysis, the patient will be having a beta 2 microglobulin. Okay, a beta 2 microglobulin.